The next MPN is polycythemia vera that is featured as panmyelosis in the bone marrow with increased erythrocytes, granulocytes, platelets in the peripheral blood, and splenomegaly is commonly present. It is caused by an acquired point mutation at the GAK2 gene. Such mutation makes the gene product GAK2 protein constantly active as a tyrosine kinase that phosphorylates STAT, an activator of transcription as shown in the figure on the bottom right. With such mutation, JAK2 transcription is activated without the presence of erythropoietin, while the upper panel of the figure shows you what occurs normally without JAK2 mutation. Transcription is only activated when erythropoietin is present. In other words, with such JAK2 mutation, the production of blood cells is out of the control by erythropoietin. The two major criteria for PV diagnosis are hemoglobin higher than 18.5 in male and higher than 16.5 gram per liter in female, and identification of JAK2 V617F mutation, which means at position 617, V line is replaced by phenylalanine. The three minor criteria are panmyelosis in bone marrow, low serum erythropoietin, and autonomous erythroid colony formation in vitro, based on WHO standards to be diagnosed as PV. Either two major plus one minor criteria are met, or one major plus two minor criteria are met. It is challenging to differentiate PV from erythrocytosis secondary to hypoxia or erythropoietin-producing neoplasm. The latter two have no granulocytic or megakaryocytic hyperplasia in bone marrow. As shown in the table, erythrocyte, granulocytes, and platelets are all increased. So are hemoglobin, hematocrit, and red cell volume. The red cells are normocytic and normochromic. The image on the top left is a peripheral blood film from a PV patient shows you normocytic and normochromic red cells. Do you see any lymphocytes? No. So all increased except for lymphocytes. The image beneath it is a bone marrow biopsy specimen that shows panmyelosis, a lot of normoblasts that can collect in large clusters, enlarged megakaryocytes with lobulated nuclei. Clinically, PV patients always have increased red cell mass. They often have splenomegaly or hypersplenism, meaning they have enlarged spleen, bone marrow hyperplasia, but peripheral blood cytopenias. Treatment is to use phlebotomy together with myelosuppressive agents, control complications. Essential thrombocythemia, by definition, is a clonal MPN with increased megakaryopoiesis and thrombocytosis, with platelet count usually higher than 600 billion per liter. 450 billion per liter is the threshold defined by WHO. The two major complications associated with ET are vascular occlusions or bleeding. Four criteria must be met in order to be diagnosed with ET based on WHO. First, platelet count is more than 450 billion per liter. Second, bone marrow has large mature Lokenbach karyocytes without increased erythropoiesis or granulopoiesis or left shift of neutrophil line. Third, the conditions cannot meet the criteria for other MPNs, myelodysplasia or other myeloid neoplasm. Fourth, patients must have JAK2 V617F or other mutations or absence of reactive thrombocytosis. Peripheral blood film shows increased number of platelets as shown in the image on the left. The platelets can be giant without granules or have pseudopods. Both bone marrows shows marked megakaryocytic hypercellularity, many more megakaryocytes than normal. Treatment is focused on the two complications, bleeding and vaso-occlusive complications. Primary myelofibrosis is featured by splenomegaly, ineffective hematopoiesis with marrow hypercellularity, fibrosis, and increased megakaryocytes. Myelofibrosis, indicated by intense fibrosis of the bone marrow, is due to stimulation of fibroblast by cytokines. Hepatomegaly or splenomegaly is due to extramedullary hematopoiesis. PMF occurs to people who are over 60 years old. They may show no symptoms or present with anemia, weight loss with left upper quadrant pain caused by enlarged spleen. Peripheral blood film shows teardrop red cells as shown in the image on the right. Nucleated red cells say in both images and immature granulocytes. Two immature myeloid cells are seen in the image on the left. You can also see giant platelets. Bone marrow examination shows intense fibrosis, granulocytic, and megakaryocytic hypercellularity, dysmegakaryopoiesis, dysgranulopoiesis. Treatment can be very diverse depending on the patients. Average survival from the time of diagnosis is about 5 years. The most successful treatment by far is transplantation for patients who are younger than 60 years old. For the four PMNs we have reviewed so far, GK2 mutation are identified in three of them except for CML. That's the end of this lecture. Thank you very much for your attention.